Hi, I'm Vince today. I'll be teaching you guys some real good tips for how to take the ACLS test today and how to keep things simple for you to make sure that you're doing things right and not really freaking out about your written test, but that's what we really think about the most. We're going to go over some algorithms with you guys today. And let's start from the get-go with the algorithms. We have tachycardic algorithms. We have bradycardic algorithms. Just remember this. Keep it as simple as possible, guys. Listen, bradycardic rhythms, you want to put a gas pedal on them. Fast tachycardic rhythms, you want to put a brake pedal on them. You want to slow them down and speed them up. It's a very simple concept. So we want you guys to make sure that you guys doing this. If you have a stable patient, we usually give them medicine. If you have unstable patients, we want to give them Edison. You got to synchronize cardioverter because if you let them go, they will deteriorate and they will eventually code. We don't want that. So when we're in cardiac arrest, the main important thing in cardiac arrest, and we don't like to do it, is we have to do CPR, but we have to do it at high quality. So we need to make sure that we do that correctly. If you don't do it correctly, then our window of opportunity is going to dwindle away. When we do get pulses back and we get ROSC back, we want to tend to cool them off if they're in cardiac arrest. But if it is a patient that was in traumatic cardiac arrest, we don't necessarily want to cool them off. We want to keep them warm. So post-cardiac arrest, guys, when you want to do TTM, that's for cardiac. But if it's trauma, you want to warm them up. Just remember that's a simple concept. Most systems alike are pleased when you're hooking up patients. A patient is having an ACS, a patient's having chest pain. Let's do 3 simple things. Let's get them on the 12 lead. Let's get an IV start and let's get those labs sent out. If you guys do that, you guys are going to be golden. So remember, we have to do some things prior to treatment. If you don't do things prior to treatment, then we're going to be in some trouble. Okay, so when we're running any type of patient and you're looking for patients that are stable or unstable, how do we differentiate for unstable, unstable? Easy blood pressure. We have to know what our norms. Our normal blood pressure should be at least systolically 90. If you follow that, you should be in great shape. If you guys have any patients that go lower than that, we know that they're unstable. If they're above that, we like those great numbers. But let's think, patients that have a multitude of problems are not going to have those wonderful blood pressures of 118/78. They're going to have these very low systolic blood pressure. So we have to think, do we have to speed them up? Do we have to put a gas pedal on them? Do we can give them fluids or whatever else? We have to think. And if we have those very high blood pressure, we have to give them medications to lower those blood pressures. But low blood pressures are hands down way worse than our high blood pressures because we can work with that. Low blood pressures, our bodies do not like that organ-wise. We want to get those blood pressures up. One of our tools that we can use for stable patients or unstable patients or any patients that whether they're alive and don't have no pulse are H's and T's. H's and T's are huge. Utilize them, okay? Your hypox, your hydrogen acidosis, your acidosis, your hypo and hypokalemia, your hypo and hypothermias, your hypo and hypoglycemias. Then we go to our toxins and our overdoses. Then we go to tamponade. Then we go to tension pneumos. Then we go to thrombosis. Then we go to trauma. Use them all, guys. If you guys use them, man, that's going to make you be better at what we do. And we want to make sure that we're on top of that. So learn those things, have an interest with them, learn them, go from there. Our AHA test you take for ACLS is going to be based on unstable patients. Look at your scenarios. If you guys got test anxiety, take a look at the test, read them carefully. This is not a race. Read them. Look at your blood pressure. What dictates what we do is hands down blood pressure. If it's low, we gotta fix it. We gotta make them perfuse. So make sure that you guys definitely understand that. When we have blood pressures that are really high, we know that you gotta think, oh man, this is no good. When we have very low blood pressures, we gotta think, hey, let's get some fluid administration. Medications to lower them, fluid administration to open them up. But that's for starters. Sometimes we do need drugs to help us out. But if we can do this something less invasive, give that a whirl first, okay? So always remember that. Guys, when we have stable patients, remember, we can treat them with medicine. Remember that. If you have an unstable patient, we can treat them with Edison. That can be synchronized cardioversion. That can be pacing. And you know what? Edison is also for dead patients. Unfortunately, if we have a dead patient, we're doing CPR. But if they're shockable, you can defibrillate them. Okay? So just remember that. So here's a really good rule of thumb for you guys to remember when you guys are taking your written test. If you have a very slow heart rhythm, we want to put a gas pedal to that. And what are those gas pedal drugs? They can be atropine, they can be pacing, they can be dopamine and epi. Those are all chronotrope drugs, and it increases your heart rate. So those are what we call gas pedal drugs. If you have a very fast heart rhythm, it's like a Ferrari doing 190 miles an hour. We gotta slow that thing down, slow it down. So we give them adenosine, or we give them lidocaine, or you give them prokinamide, you give them amiodarone, you can give them diltiazem, but we want to slow them down. If they're fast, slow them down. If they're slow, speed them up. Just remember that. You guys will be golden when you guys treat your patients.